My name is Ryan Aga. I'm the system-wide director of simulation for HealthPartners. We're a large integrated health system in the upper Midwest based out of Minneapolis and Bloomington and Minneapolis, St. Paul area. What I see simulation is it's a area where humans automatically connect. They come into a space around a scenario, and the human perspective is drawn into that container of space in simulation, that people are able to share their most vulnerable moments of what they did well and what they didn't do well at all. And so it's rare in healthcare, having been in healthcare over 2 decades, that teams have this opportunity to come into a space to take this time to share and to fail over and over again, and to collectively work together to improve. Simulation is that natural draw of the specialty of bringing teams together interprofessionally from physicians, nurses, respiratory therapy, security, to come into a space to train over and over to achieve better outcomes in healthcare. One fundamental piece that I find that I bring to our team and our program is the call to action by the Joint Commission, that safety and quality teams need to partner with simulation. Essentially, we've had 2 passionate teams about quality and safety, but we've been asynchronously working in different spheres and different verticals. And now with that call to action is that both teams come together, we learn off of each other and learn how to work collaboratively to make a better outcome for patients and quality and safety. This has been really cool and fun to work with. I think what takes the priority is that relationship with quality and safety. At HealthPartners, we've developed an amazing relationship with our Chief Quality Officer. And Kara has been able to see all of the quality entities across our 8 care delivery hospitals, our clinics, our dental clinics. I essentially went into her office and I said, Kara, where do you need us now? And where do you need us in the next 5 years and 10 years? So she's been able to really identify very collectively from the highest level of quality and safety on where these areas of opportunity are for patient safety and quality. And it all is fundamentally based on the relationship that you have, that it's intentional, it's partnering, we're not here to overtake, we're here to collaborate and be a tool. And so one of the areas that she identified for us to work on was sepsis, particularly an integration or a new initiative on code septic shock. So what we did is we developed a translational simulation exercise with the emergency department clinicians, physicians, nurses, pharmacy, Epic, so the electronic medical record team, safety and quality, and we brought them all together around a shared mental model of how to improve septic shock outcomes. Particularly antibiotic delivery within septic shock. So we put this team through the development of the protocol. So the policy and protocol, we use simulation to develop the policy and the protocol. Something that we have not done, traditionally in simulation, it's more of that legacy trainings with simulation. What we were able to do is use it to develop the code red septic shock protocol and policy. So we identified through that exercise and through that simulation 8 different things that the clinical team said, that doesn't work. We need more enhancement. We need a different equipment or supplies to carry out this protocol. So we created it. We iterated many different times as to the things that needed to be fixed before it went out to care delivery. And I can mention to you, like as a clinician at the bedside, if a protocol policy was developed without input of the front line, what we would quickly do on the front line is we would develop a workaround. And so workarounds are hazardous. They actually are a risk to the patient. And so what we did with this simulation exercise through translational sim is we identified those things, fixed them before they went to the front line. And we were able to improve antibiotic delivery at one of our largest hospitals by 25% from the arrival time to the initial dose of antibiotics and septic shock through this translational sim exercise all the way back up to quality, safety, and identified areas that needed strengthening. So it's mostly fundamentally the relationship, how to develop that with quality and safety, and then really identifying where are the pinch points that they need simulation. I feel that simulation is the catalyst to all improvement. And I mentioned in my presentation today in the Laerdal Sun Conference that really simulation is like liquid gold to an integrated health system. It is teams of people coming together, ability for them to fail in a safe, brave space, and to have that dialogue of what is it, what do you need, and they feel safe to do it in a space that's otherwise would have felt unsafe or at risk. We are housing probably some of the most rich data for healthcare organizations globally is within simulation. And so really democratizing that this is a very, very powerful specialty, that we have essentially everything from the front line that our front line is saying is incorrect or needs improvement, or in the safety 2 context, things that are working very, very well. And so for a learning organization, to embrace simulation from a long game perspective, simulation is it. It is the core construct of learning through academia and health systems, because we've got all of this rich, amazing data that should be shared, disseminated up and down the verticals and across to save patients' lives is key. I would say one of our last threads to keeping us financially sound or supported is value-based care. And that's all based on quality and safety. And so leaders, I think they've been now, gosh, I don't want to use that term, but they've seen the successes of simulation and training. What now they need to shift towards is how simulation not only can be used in training procedural, but how can simulation be used for new technology integration into a health system? We are in the immersion of an AI tsunami. How do we use simulation with an AI tool that comes into a large integrated health system? How do we use simulation? How do we interact with AI? How do we bring teams together, just like we have with legacy training and education simulation, and use simulation across all entities of the healthcare construct? And I think leaders in healthcare have been just still traditionally down that track that simulation's used for education and training. But when you look at the value-based care, and what I just talked about is that a 25% improvement on antibiotic delivery, your patients are going to survive, you're going to have less regulatory burden, and so double downing with simulation on quality improvement, return on investment, to keep us financially supported and growing in healthcare it's no longer a nice to have. It's a moral ethical that it's a must have in healthcare organizations to keep them fundamentally running and for the future.